I truly believe that managing end-of-life decision-making is a critically important function of the clinician. I believe that wherever possible the question should be raised and good solid discussions held with the person and their support people or their family.
I guess we can improve the situation by being open and honest with patients. So firstly about their care, about what the expectations are, and about what they really want out of their admission and what they really want out of their illness as well.
Yes, there's two questions that can be asked all the time. Firstly, you could ask a patient, if you were so unwell that you couldn't talk about your treatment to your doctors, is there someone else that you would want to speak for you? I guess the follow-up question, the second question would be, have you actually discussed this with that person?
So the first thing is to actually have that conversation, to actually understand what the patient's wishes are, understand what the family's wishes are, getting some feedback from the other members of the allied health team who may know the patient much better than you do and understand where they are in their lives.
In all medical procedures, patients have responsibilities as well as the doctors. The best ways that you can have discussions about CPI is to have had them early with family members so that the family's not trying to second guess what your wishes might be.
The general practitioners need a role in this to actually speak to patients before they ever come near a hospital. Specialists in medicine and surgery, cardiology, all the other specialties need to actually address these issues in their outpatient clinics.
It gets confusing, advanced care planning and advanced care health directives and all the terminology, but the long and the short of it is, if in different settings we're having this type of dialogue, patients actually become educated, aware of the realities of resuscitation, but also medical treatments. They don't always work. And they're much more likely to make decisions that are in their own health interests and have a good outcome, a good experience of healthcare, but also a good death if their time is up.
Managing end of life and dying is not something that can be subject to some kind of protocol. It isn't like having a heart attack where we know that if we give people some aspirin or something like that, that this will have great benefit and is applicable to the vast majority of people. There's a very high variability in what people would regard as a good end-of-life management or as a good death. And we should therefore resist the idea that this is protocolized. What we really want to do is to systematize it so we know that we have a system and that people will be spoken to and that there will be some intervention and that there will be some interaction and conversation. But we want to preserve variability.
CPR and end-of-life discussions can be quite straightforward and in fact extremely enlightening. If the family has had the discussion, if the level of understanding and knowledge is high, then you'll find that you have extremely strong support and strong advocacy for making your decision.